you to think about it too. And to hope you hope that you can see, oops, that's my email, you don't want to see that. Hope that you can see that there is some um, similarities between adrenergic and anticholinergic, as well as cholinergic and antiadrenergic. So here we go. Um, so adrenergic medications we haven't studied yet in class because those are respiratory medications, but we can expect that anyone who takes a medication that activates the sympathetic nervous system or is adrenergic will experience the things that we studied for the quiz, which is um, activation of the sympathetic nervous system. I mean, we used it for the respiratory system, but we know there's always crossover. So that's the pupil dilation, tachycardia, elevated blood pressure, bronchodilation, slowing down of GI and GU motility. So we have to be careful about driving in the day and be sure if to increase fluid intake. Those are some education things we can do. And then if these are the potential side effects, then we'd have to be careful with people that have a history of bowel or bladder dysfunction because we're slowing their bowel and bladder activity down. If they already have bad hypertension or arrhythmias or coronary artery disease or angina, we'd have to be careful because we're revving up their cardiovascular system. So, yes, so now you can use it. So now I will upload this one too, and then I would suggest using the blank form now that maybe it's more clear to hopefully that the ways that you could use it to study. So that's what should be an adrenergic. So adrenergic, um, anti-adrenergic would be if those alpha and beta receptors were blocked. And those are medications that we learned about. Doxazocin is that alpha blocker that decreases blood pressure by blocking vasoconstriction, and metoprolol decreases blood pressure by, yeah, I'll share it with you guys. Decreases blood pressure by blocking the beta receptors. And so even though we are not activating the cholinergic receptors, we will have a response that's closer to the parasympathetic nervous system because we're blocking the adrenergic receptors. So we can expect the opposite: pupil constriction, bradycardia, vasodilation. It's not easy to bronchodilate, and then the GI and GU system increases. So the directions are: be careful when you're driving at night, could increase frequency of bowel and bladder activity. So then we have to worry about the people with arrhythmias that are slow arrhythmias, or if they have asthma or already have low blood pressure, low heart rate, or if they have obstructed intestines or bladder, because if we increase contractions when someone is completely obstructed, then all we do is cause a lot of pain and pressure at the area of obstruction, and we don't help it at all. So we shouldn't do that. And then the opposite, instead of adrenergic receptors, we can look on the other side here, which is cholinergic receptors. So if we actually activate the cholinergic receptors, and we've learned about, or the last class, hopefully you watched the video as I had made, was about bethanechol, which activates the cholinergic side of the parasympathetic nervous system, and pyridostigmine, which activates the cholinergic receptors on skeletal muscle. So this is actually activating the cholinergic receptors, activating the parasympathetic nervous system. So it's similar, which is why they're both shaded, similar to the anti-adrenergic side. So the same things apply as for anti-adrenergic to cholinergic. Anticholinergic is blocking the parasympathetic nervous system response. So it's matching the adrenergic. It's similar to the sympathetic nervous system, and that medication is atropine. So we have similar cautions and side effects. The only difference is that only anticholinergic medications should be avoided in myasthenia gravis, because the only area with cholinergic that has skeletal muscle has cholinergic receptors. So even though atropine is only supposed to work on cholinergic receptors in the parasympathetic nervous system, it can cross over to cholinergic receptors that work on the skeletal system, and someone with myasthenia gravis is already weak muscles. So that's the only box, anticholinergic, where myasthenia gravis isn't. Those people with that condition shouldn't use that medication. And I just wanted to draw your attention to that because that's always a question on the test. So we want to be sure you're successful. So I will upload this so you can see the answers, but I encourage you to use the blank one to try to fill it in as a way to study. Okay, so that, well, I was having a good time, but I'm sure you were not. So now we're going to move into the next stuff. And I tried, what I was told was that I should be able to upload things into our class if I got rid of some of the recordings, like maybe it was too full, but that still didn't work. So I again uploaded our PowerPoints to our calendar just so that you have access to them. So the next group of slides or medications are for neurodegenerative disorders, which are disorders that are related to breakdown of the brain, as well as medications that are for seizures. So we'll start with the neurodegenerative disorders, and the two disorders that we're talking about are Parkinson's disease and Alzheimer's disease. Parkinson's disease is a breakdown in the area that's in charge of some of our fine movements and the area where we smooth movements. It's called the basal ganglia. And this area's biggest job is to create and make dopamine. And we need in our brain itself, because our frontal lobe is in charge of movement. It's one of its many jobs. And this is voluntary movement. And the basal ganglia is sort of helps the frontal lobe ganglia with smoothing out the movements, taking away tremors, being sure that there's follow through with the movement, that there's coordinating movement. So it helps us be more graceful and coordinated with our movement. The part in the brain that is in charge of movement, the neurotransmitter that is used in that section of the brain is acetylcholine. The part that smooths the movement in the basal ganglia uses the neurotransmitter dopamine. And so for our movements to be normal, these neurotransmitters need to be in balance. So it should be like a scale. We should have activity in the frontal lobe and activity in the basal ganglia. And if they're both working together, then we wouldn't notice anything like tremors or rigidity or difficulty starting movements, etc. When somebody has Parkinson's disease, their frontal lobe, or the area that's in charge of the movement, is fine. So we still have the acetylcholine, and we're still sending messages to the body to move, or for skeletal muscle movement. But the basal ganglia, for some reason, the nerves inside there break down. Sometimes it's genetic causes. It kind of can be that. It could be related to heavy drug use or multiple trauma, or lots of trauma to the head can cause that. So that means if this is starting to decline, we're going to have a decrease in overall amount of dopamine, and now the scale is out of balance. There's less dopamine and more acetylcholine, and that's what leads to the symptoms of Parkinson's disease, where there's a lot of tremors, there's rigidity. So once the movement is started, it's hard to get that muscle to relax. Um, there is difficulty starting a movement. So I decided that I want to try to put my shirt on, and it's going to take a while for me to send that message to my muscles to actually do that. That people tend to be stooped over posture wise, and so there's a falls risk, and it tends to flatten the facial muscles. And so you can't tell, even though the patient says it doesn't affect the frontal brain, which is also your personality and decision making until the very end. Even though that is fine, the person may be feeling emotions, is feeling emotions and is understanding things cognitively in the beginning. They aren't able to express that on their face. So towards the end of Parkinson's, people can develop dementia and depression and things like that. But in the beginning, that's not the case. It's really that they have physical issues. And when you give someone with Parkinson's disease medication, what you're trying to do is keep them able to move around and increase their ability to take care of themselves. You're not going to cure Parkinson's disease at all with medication. So this is important. This is usually a test question. What is the goal of treatment for Parkinson's disease is to be sure that the patient can actually take care of themselves for as long as possible, that they're able to do their activities of daily living for as long as possible. So if someone's on Parkinson's medications, they're on it forever unless we find a cure for Parkinson's, which we have not. There are or have been trials of using stem cells to try to regrow the basal ganglia, but those depends on who's in charge, whether or not stem cell trials are allowed, depending on how you feel about stem cells, or harvesting stem cells from fetuses. So it depends.
I have a
Depends on
question.
who's around. Yeah, good.
Hello?
Yeah, go ahead. Go ahead.